Heart murmurs, boring? Not at all. Really, really, really interesting. So, any of you guys, do you all listen to heart murmurs? Yeah. Do you know what a heart murmur is? Can anyone happy to say this is what a heart murmur is? Yeah, that's fine. We have loads and loads of visitors that come in through cardio, lots of intern nurses, lots of just people that come through. And I always say to them, oh, what do you want to know about cardio? And I'm thinking, oh, they want to know about some congenital disease, something really, really interesting. And they say, no, heart murmurs. I need to be able to identify what a heart murmur is, grade a heart murmur, timing, location, because if you have all that information or you have that knowledge, you might be able to say, oh, this could be this, or this could be this, and then we look really, really clever, okay? Because the vets listen, you know, we have surgeons that will listen, we have orthopods that will listen, and they'll be like, yeah, there's a murmur, and I'm like, oh, okay, what grade, location, timing, and I'm like, I don't know. So hopefully from this talk, you'll go away with some knowledge, be really, really enthusiastic, hopefully, about murmurs, and then be able to say, oh, I know what this could be, give you some differentials, okay? As well as obviously going through lovely Ralph and sort of identifying why we need to listen and identify what is going on with his murmur. Implications then for anaesthesia, do they need to be concerned, or do we need to do something more for this dog with regards to cardio? Okay, yeah, so let's move on. Okay, so basically, what are heart murmurs? When I ask people what is a heart murmur, I get really amazing terminology. But all a heart murmur is turbulent blood flow. That's all it is. So when you see blood going around the heart on an echocardiography, or you listen and you hear the lub-dub, that is just laminar flow. So it explains there, laminar flow is smooth, constant fluid, and it's a silent flow. Okay, but when you hear a heart murmur is turbulent blood flow and it's chaotic. So what that means is, it's for some reason, there's turbulent, there's high velocity, there's high pressure, there's lots of things going in the heart that can cause a heart murmur. But you probably know heart murmurs can sometimes be significant, so hemodynamically significant, or they actually can be benign. So there are murmurs that you don't have to worry about at all. But how do you know? Okay, so what are heart murmurs? As I said, they're turbulent, and it's the change in viscosity of the blood. So for instance, with Ralph, if he's anemic, he's hypovolemic, that can change the viscosity, viscosity of the blood. So therefore, you're going to get a murmur. But is that significant? Altered diameter of vessels, so vasoconstriction, that cause almost a stenosis of the diameter of the vessels and can cause a murmur. Is that significant? Changes in flow, so the speed. So I'm going to play this little tap. This was at the Ralph. So I can show you what laminar and turbulent blood flow is just by the tap. So that's laminar. You increase the speed and the velocity, and you can see, now you can hear it. And also, you can also actually see that it actually goes clear, and then you can't actually see through it. So laminar flow is transparent. There we go. And that's it. And also you can do the hose pipe analogy. So if you think of a hose pipe in the garden, you've got normal laminar flow, and then suddenly you put your thumb over the hose pipe at the end, and then you've occluded that diameter, and so therefore you've got an occlusion, and that blood then goes through a lot faster, higher velocity, higher pressure, and that's what causes the murmur. Okay? So that slide just says, so the change in flow, speed, velocity depends on the difference between the pressure that pushes the blood versus the pressure where the blood is trying to go, okay? And then your increasing pressures means increased bleeds. And then we also have something called mixed blood flows. So in cardio, we have, obviously throughout the heart, the blood should hopefully go one way. But as you know in cardio, because it's really, really interesting, we have lots of different cardiac conditions can make the blood go in different directions. So holes in the heart, communications where they shouldn't be, high pressures in the lungs can push the blood all different ways. So a mixed blood flow can cause also a murmur, turbulent blood flow, okay? Oh, no, I can move that on. There we go. So just a generalisation of the heart. I'm sure you're all aware. So you've got your left ventricle, your left atrium, wonderful aorta, and you've got your mitral and your aortic valve. right side your right ventricle, right atrium, you've got your tricuspid and your pulmonary artery with your pulmonic valve. So they're all the valves and the chambers of the heart that we look at when we do scans. So as I said, abnormal flow direction, so you have your septal defects. So if you've got any communication where it shouldn't be, any kind of holes, where the septum should be, there's a hole, you get blood moving, generally from left to right, just because of the pressures, but that's going to cause a murmur. PDAs, so really long terminology. Cardio love to use long terminology, but it's patent ductus arteriosus. Don't worry about that. It's just a congenital defect that causes abnormal communication between the pulmonary artery or the aorta and the pulmonary artery, and so the blood shunts where it shouldn't. Insufficient valves. So this is probably one of the most common things that you'll see. Mitral valve degeneration. You probably see that quite a lot in your Cavaliers. Yeah, they're the bread and butter of cardio, Cavaliers. So mitral valve, tricuspid, aortic and pulmonary. So insufficient valves. Just over time as dogs and cats get older, dogs predominantly, their valves become degenerative, and then that in itself will cause a turbulent blood flow. And then you also have abnormal narrow strictures. So literally your ventricular outlet. So your quite a very common cardiac condition, congenital cardiac condition, is pulmonic stenosis, where the valves are stenotic. And so therefore you'll get turbulent blood flow across that valve as well. Okay, so why do we care about murmurs? Well, number one, because cardio is amazing. But most importantly for you guys, it can affect the heart's ability to pump blood around the heart, okay? So in Ralph's case, he came to us for cardio because he had a murmur, and anaesthesia want to obviously intervene because they want to deal with his hemorrhagabdomen. So what happens if the patient's got a murmur and then we need to put sedation and anaesthesia into the mix? So if you've got a hypovolemic and anemic animal, you've got less oxygenated blood going around the body. So the heart is thinking, oh my God, I need to get more oxygen around this body, so it pumps a lot harder, works a lot harder. You then give sedation or anaesthesia, and some anaesthetic drugs cause myocardial dysfunction, so they might depress the myocardium, so the heart muscle might not work as well. It can also cause bradycardia. So all kind of things that will work against the heart when the heart's trying to work harder. So we really need to answer some questions for our wonderful anaesthesia team to say, actually, take this into consideration, or actually, no, we're all good to go, okay? And then, just to make it more interesting, some murmurs are innocent or benign. So without doing a scan, we're not going to know whether this murmur is innocent or benign. And some animals, especially cats, typically cats are always the difficult patients, aren't they? So they can have a murmur and it's just completely benign. It's just because of their hyperdynamic state. They get obviously quite stressed. Their heart's pumping really hard, and they get something called, it's a mouthful, it's called Dr. Voto, which is dynamic right ventricular outflow tract obstruction. Sounds amazing, but all it is just where the heart is pumping so hard that it causes an obstruction. But it's completely benign. And without scanning a cat, you're not going to know. So send them to us because we need to scan them. But obviously then sometimes the murmur is only the sign of a heart disease. So you could have a clinically well patient and they've got quite a significant heart murmur, and the only way we can tell you is to be able to scan this patient. Yeah. Oh gosh, okay, you're going to make me say it again. It's called Dr. Voto, so you can sound really, really clever by saying that, or even more clever by saying dynamic right ventricular outflow tract obstruction. Okay? Thanks for making me say that again. Okay, right. So for us guys as nurses, okay, this is what we can do, and I'm hoping that when you leave here, this is something that you can think, oh, okay, I'm not just listening to the whooshing sound. There's much more details to be involved here. So, timing. Is it during systole or diastole? Is it during S1 or S2 sound? Tip, always say it's systole, because 9 times out of 10, it's not going to be diastole. If any of you work with horses, because the heart is so slow, you will hear a diastolic murmur. But tip number 1, always say systole, 90% sure, okay? Location, is that okay to say that? I'm just looking at location. So you can tell so much by listening where in the heart you're actually listening to this murmur, okay? So you put your stethoscope on, you think, yeah, it's in the heart. But actually, if you move it towards the apex or the base, it can give you some differentials of where this murmur is. And I tend to do this quiz with any visitors or any students that we get in. I get them to do the timing, I get them to do location, and then we have a little bit of a quiz. Okay, so where is it? Okay, so what would be your top differentials for this murmur? And then the intensity. So you will have, are you all happy to grade murmurs? Yeah, yeah. So generally we grade murmurs 1 to 6, okay? Generally the rule of thumb, the quieter the murmur, then it's not normally too much of an issue. There are always exceptions to the rule. But obviously if you've got a grade 5, grade 6, this really needs to get investigated. Okay, so these are really, really important questions that you can test yourself when you're listening to murmurs. Okay, so as I said, if in doubt, say it's a systolic murmur, okay? Because this is when during systole the ventricles contract, and for example, you'll have a mitral tricuspid regurgitation or pulmonic stenosis. So there you go, you've got your S1 and your S2 sounds, okay? And then they do this fancy stuff in cardio where they say it's holosystolic, pansystolic. Don't worry about that. It just makes us look clever. Diastolic is when the ventricles relax. So you might have that for aortic insufficiency or mitral stenosis. So just by having a look at the timing may give you an idea of what kind of murmur you've got. Or the best one is continuous. So this murmur happens throughout the whole of S1 and S2. And this, if you hear a continuous murmur, you can just put your hands up and say, yep, I know what that is. This is where you get the congenital condition, patent ductus arteriosus. And it's a continuous murmur, and that's simply because there's a communication, the ductus hasn't closed, between the aorta and the pulmonary artery, and so the blood just continually flows across. So if you hear a continuous murmur, 99.9% of the time, it's going to be a PDA, a patent ductus arteriosus. Unless it's some weird and wacky thing, and we wouldn't even guess that either, so, okay? And then you've got your inducible murmur. So, this is something that you can do when you go away, is listen, especially cats. If you hear a murmur on the right side of a cat, put your stethoscope on, press a little bit harder. Can you hear a murmur? Release the pressure, and the murmur goes. So it's an inducible murmur. And it's just the conformity of the chest that you can actually induce this murmur. And it's completely benign. And we get a lot of these cases come in, and that's absolutely fine, but we would just imply different intensities of this chest wall, and we can actually produce a murmur. So it's quite interesting, quite cool. So there's our bread and butter, our lovely, wonderful Cavalier King Charleses, okay? So instantly we get a cavi into cardio, and I'm thinking, oh, that's going to be mitral valve degeneration. Okay, so that's my top differential. So this is lovely little Toby, 7-year, 4-month-old, and I'm going to play, fingers crossed, a heart murmur. Okay, can anyone hear that? You can? Yeah? Would anyone, now I've given you the tip, would anyone like to say, is that an S1 or an S2? Systolic or diastolic? Yes, yes, exactly. Okay, can you hear it? It's not that loud. Sorry, Elliot, sorry. Hear that? Yeah, you can hear the lub dub, and then you can hear that amazing whooshing sound, but you can only hear the whooshing sound just at the S1 sound, yeah? Okay, so my top differential for this would be mitral valve degeneration. You obviously have to scan, but you actually look amazingly clever if you can give that as one of your top differentials, because it probably will be. Oh, there we go. Now this is lovely, lovely Daisy. Daisy is a 1-year-old, 6 months Yorkshire Terrier. And let's listen to little Daisy's heart sound. Can you hear it? That's a beautiful sound. So anyone want to give a guess of what that might be? Sounds like a washing machine, yeah? Can anyone differentiate between S1 and S2 there? No, so it's continuous. So that's your wonderful PDA. Yeah, and I say wonderful because sometimes cardio can be quite sad, but with a PDA, we can do a procedure and it's curative. So it's a good sound because we know that we can do something about this. This is where the communication is between the aorta and the pulmonary artery. So that's a continuous sound, yeah? So you can sort of tell the difference, yeah? And I think the more you get used to listen to murmurs, you'll be able to differentiate. Oh, it's there again. Let's just move on. Oh, there we go. So, location of murmurs is really important as well. So when I listen to any animals, dogs, cats, left and right, because obviously you can differentiate between which valve you're listening to, whether it be left or right, or base or apex, because that will also tell you whereabouts in the heart you're actually listening to this murmur. Cats, as per usual, slightly difficult. You can do left or right, but you can't do base or apex. The heart is so small, it really is. I mean, if you can do base or apex, all good. I can't. I just have to do whether it's sternal or parasternal, okay? Okay, so grading of murmurs. This is how it's universal. This is how everyone generally grades murmurs. There's different terminology, but how I would always do it is between grade 1 to 6. And I think across all cardio departments, that's how they're going to grade murmurs, okay? And I think all your vets and everyone else in your practice will probably grade it like that. So grade 1 is where there is no background sound whatsoever. You've got no computers, you've got no one talking in the background, and you might, if you're lucky, hear a grade 1. If I can hear a murmur, I always say it's grade 2, because grade 1 is so subtle, and you have to have really clean ears and really good hearing to be able to hear a grade 1, okay? Grade 2 is soft. You can hear it. So grade 2 is soft, but it's quieter than the heart sounds, okay? So you can hear your lub-dub, and then in the background you can hear the whooshing sound, okay? So that's a grade 2. It's quite a subtle sound, okay? Grade 3, so grade 1 and 2, sorry, sometimes people class it as soft, okay? Grade 3 is called moderate, and it's as loud as the heart sounds. You can hear the lub-dub, but you can also hear the whooshing. So if you're listening to a murmur and you think, oh, I can't tell whether it's louder or quieter, generally it's going to be a grade 3, okay? Grade 4 is classed as loud, and it's louder than the heartbeats, okay? But as I said, it really all depends. Everyone's stethoscopes are different, everyone's hearing's different. Between 3 and 4, it's kind of subjective. So don't worry if someone says 3 and you say 4, it doesn't matter. Grade 5 is where we get really funky, because this is where we get our palpable frill. So this is where you can put your hands on either side of the patient's chest, cup your hands, and you can feel. It's not the apical beat. So some people think, oh, I can feel a frill, and the apical beat is like a real pounding. A frill is like a buzzing of bees. You can feel like a vibration across your hand. So just feel, I mean, it's amazing when you feel it. It really is a super cool sensation on your hand. And then a 6, tends to be the cavies, is where you can hear the heart sound without a stethoscope. So you can, I don't know if any carers have come in to you guys and said, oh, I can hear. We have carers that come in and they'll say, I can hear the heart sound, I can hear the murmur. And you're like, and you actually can walk into a room and hear it. So, which isn't the best. Okay, so I'm going to play. So as I said, grade 4 and grade 6, I've put question mark because they're so subjective, okay? So let's hear the first one. Yeah, everyone hear that? Would you say that's kind of louder than the lub-dub? Yeah. Okay, that was the dog. And then grade 3. Yeah, so that's, you can sort of understand, appreciate that actually this one's a little bit quieter than that one. But it's very subjective. And now here's a really funky one. That's really cool, isn't it? Yeah. It's not a squeaky toy inside the patient, I promise. It's not. It's just, we classify it as a squeaky murmur. It's amazing, isn't it? And that all is, so that, if I hear that kind of squeaky murmur, that generally means some sort of defect on the mitral valve. And we do, so we have to obviously describe all the murmurs on our paperwork, and we will actually say squeaky murmur. So don't, if you want to say squeaky murmur, it doesn't sound very technical, but it's how we describe it. And we can generally say that that's a mitral valve murmur. Yeah.
Is that always grade 6,
No, not at all. No. So it really all depends how the intensity of that squeak. So you can hear a squeak, but it could be a really loud squeak or a really quiet squeak. Yeah? All right? Okay. Oh, I'm not moving on. There we go. So this is lovely Ralph, getting back to Ralph. So this is me auscultating Ralph. He looks very happy. Doesn't look like he's got a hemoabdomen. I got him on a good day. So this is lovely Ralph. But I just took this picture because when you listen to murmurs, so I look really quite happy here and then I look really serious here, because when you listen to murmurs, it's really, really important that you don't confuse it with respiratory sounds, because when the dog's panting, you're all nodding so you can all hear and you think, God, is that the murmur or is that a respiratory sound? Okay, so just gently closing the muzzle just so that you can hear actual nice crisp heart sound, because we do get lots of patients and they have, for various reasons, they have really, really loud respiratory sounds and it can get confusing. Is this a murmur or is this respiratory sounds? And that just comes with just listening and, just a bit of just listening to murmurs all the time, and you will get used to that. Okay, so lovely Ralph. So when Ralph came into our cardio department, obviously we were told he was an 8-year-old golden retriever with a hemoabdomen. So instantly you start to think, okay, in cardio we can do breed specifics because he's a golden retriever. He could be or could have subaortic stenosis, mitral valve dysplasia, or hemangiosarcoma. So that is because of his breed. Okay. When we listen, we can listen and see that he's got a grade 2 heart murmur with a PMI, a point of maximum intensity, over the left apex. So to me now, instantly, he's 8, soft, and it's over the apex. So my top differential is going to be degenerative mitral valve disease. And then we could have mitral dysplasia, but that's generally in young dogs. So I'd kind of exclude that. Endocarditis. Could be because you get the murmur over the apex, but you'd have vegetative lesions on the valves, all that type of stuff. It's there in one of my differentials, but we'll have a look. And then dilated cardiomyopathy. He's not generally the breed for it, but we could have a look and see. So already I've because I've listened to this murmur and I know what the murmur sounds like, I've got some differentials. And then of course, he's got a hemoabdomen. So that's going to change the blood viscosity. So I need to now think, okay, he's anemic. He's got hypervolemic, and there's also systemic inflammation, and they can all cause murmurs. So the question is now, is this dog safe to go to anaesthesia? What is the cause of the murmur, and is it hemodynamically significant? Okay, so this is what we do in cardio. We'll do a scan, okay? And so obviously clinicians do scans, but nurses can scan too. We really can. So we scan. Obviously we can't diagnose completely, but we can scan. It's a really good fun aspect. We can get on and have a little bit of have a look at all the heart chambers and stuff. So this is what, I love to jump on and scan as quick, whenever I can. So it's a non-invasive. Patients don't really mind it. We have a look at the heart chambers. So that's your left ventricle, your left atrium. That's called your mushroom view because it looks like a mushroom, doesn't it? Makes sense. That's your mushroom view. That's your left ventricle. And then we also look, so it says here Doppler. So we look at the Doppler interrogation. So we have a look at the blood flow across the chambers because we need to find out where this turbulent blood flow is. So blue and red is a laminar flow. Any different colours, so like we have a yellowy greeny, means it's turbulent blood flow. And that's where we'll have a look. And we also assess all our chamber sizes, okay, because we're anemic, we're hypervolemic, we need to check these chamber sizes so we can let anaesthesia know. Be really careful with fluids, be really careful with the drug choice, no opioids, careful with sort of the sedation anaesthesia that you're going to use, alpha-2s, not opioids, alpha-2s, because it could have a significant effect on the heart, okay? So that's kind of what we do. Then a full report happens. So all the chamber sizes, all the measurements, the clinicians will do, and they'll have a look. They're obviously all normalised for the particular breed. We upload images, so that's the the TFAST that lovely Sarah was talking about, the LAAO. We do that as well and have a look, and we just have a look at all the, as I said, all the chamber sizes. Doppler interrogation. So here you can really appreciate, you can see the velocity there, you can see all that blood flow there is really turbulent. So we focus on there and say, okay, there's a lot of turbulent blood flow. Why is this there? What is the velocity? Is it hemodynamically significant? This is Doppler interrogation, just tells me the speed of the flow of that blood. Do we need to be worried about it? And then a full report, okay? And what anaesthesia want to know, there are no observed cardiovascular abnormalities that would pose an increased risk to general anaesthesia. So that's kind of what we do for anaesthesia. Or any patient that's in the hospital that's got a murmur. Or any of you guys, if you send patients and they need to have a dental or a procedure, this is kind of the report that we will send on just to say, don't worry, all good, go ahead. This little guy, Ralph, didn't have anything hemodynamically significant. He had mitral valve stage B1. So in these cases, we see them back yearly. As I said, he's an 8-year-old golden retriever, got degeneration of the mitral valve, and we'll just check that every year just to make sure, because it's degenerative, it will get worse. So we just monitor that. Okay. There we go. Thank you for listening.